Okay, so the last four topics that are remaining are these four. So we have esophageal tears, diaphragmatic injuries, airway foreign body aspiration, and aspiration pneumonia. So I'll try to go through them quickly, but also I'll try to make it a bit interactive because some of these signs you've already reviewed them with Dr. Taleni. So first we'll start with esophageal tears. So by definition, an esophageal tear is a breach of the esophageal wall, meaning any break it can extend partially through the wall or completely, resulting now in a complete tear. So esophageal tears are known to be the most common cause of mediastinitis, attributing to about 90% of the causes. And when it comes to now chronic causes of mediastinitis, then we should start thinking along the lines of chronic infections like TB or fungal infections like histoplasmosis. So it's also good to familiarize ourselves with radiological signs of either of these acute traumatic causes of esophageal tears and chronic causes of mediastinitis. So just remind ourselves of the normal anatomy of the esophagus. We know the esophagus is a tubular structure and it measures approximately 25 centimeters. The upper extent is defined by the cricopharyngeus muscle, and that extends roughly from C6, and then it passes anteriorly to the vertebrae within the thorax, and towards its inferior extent in the thorax, it veers slightly to the left before it pierces the diaphragm at T10. Then we have a short abdominal part of the esophagus, after which it joins the stomach at around T11. So that is just the normal anatomy. And the image to the right just shows the relations. So this is a esophagogram and it's showing, yes, the normal anatomy. So in this image, I'm sure it's familiar to us. Does anyone want to tell us what are causing this, should I say, compressions on the anterior aspect of the esophagus in image B? Anyone?
Let's have people quickly volunteering so that we don't waste time. Or you want me to call out names?
I can.
Okay, Talani.
So the one is being caused by the aortic arch,
Yes,
and then two is by the left main bronchus.
true.
What are the other? It's just those two, right?
Yes, for image B, it's just these two. Then I can mention image C. So inferiorly, just before we get to the gastroesophageal junction, we also have this constrictions. So number 4, we know it's the vestibule. Then we have the A-ring, which is this white line demarcated by number 2. And then we have 3, which is the B line. And then 8 is the diaphragm. So that is just the normal anatomy. So, according to the American Association of Surgery for Trauma, they've classified esophageal tears into these 5 different types. So, in grade 1, you have just a contusion or a hematoma within the esophagus itself, accompanied with a partial thickness laceration. In grade 2, you have a laceration that only involves less than 50% of the circumference of the esophagus. Grade 3, it's when it involves more than 50% of the circumference. Grade 4 is when you have segmental loss or devascularization of less than 2 centimeters, and 5 is more than 2 centimeters. So surgically, this is how they grade it. I didn't come across how they grade it radiologically. So when it comes to the causes of esophageal tears, we can broadly look at it in 2 ways. It can be iatrogenic.
When it comes to trauma, we use the AAST for
Oh,
everything.
okay.
Yeah.
All right, thank you. So for the causes, we can broadly look at it in 2 ways. It can be iatrogenic or traumatic, of which iatrogenic is the most common mechanism. So under this, we have commonly endoscopic procedures resulting to esophageal tears. You can also have nasoenteric tube placements and other surgical procedures that involve the esophagus. For the traumatic causes of esophageal tears, you can have either penetrating or blunt injuries. Blunt injuries being commonly as a result of motor vehicle accidents, penetrating as a result of gunshots or stab wounds. You can also have foreign body ingestions like the ingestion of fish bone. You can also have spontaneous ruptures like in Bohave syndrome, which happens due to forceful vomiting. We know to a milder extent, you can have a Mallory-Weiss tear, but on the severe extent, you can have a Bohave syndrome. And then you can also have tears as a result of ingestion of acid or other caustic substances. So this image just illustrates the difference between a Mallory-Weiss tear and Bohave syndrome. So in Bohave syndrome, you have a complete rupture of the lower thoracic esophagus, whereas in a Mallory-Weiss tear, you have a partial thickness tear affecting the gastric side of the gastroesophageal junction, and it may or may not extend to the distal esophagus. So that's a good way we can differentiate the two. So we know when we look at the esophagus, we divide it into thirds. So we have the upper third, middle third, lower third. Or you can also look at it in terms of we have the cervical esophagus, thoracic, or the abdominal esophagus, which you've seen it's just below the diaphragm. So the cervical esophagus is the one that's most commonly injured, and it has the lowest mortality. And that's because it's also easily accessible. It's easy for you to intervene and treat that specific area. For the thoracic esophagus, um, the prevalence of tears in this region, they occur less commonly, but this region has the highest mortality because of its inaccessible location and also because of the surrounding vital organs. And then for the abdominal esophagus, it's quite short. It's the one that's least commonly injured, and it has intermediate morbidity and mortality. So if we compare penetrating and blunt injuries, penetrating injuries, they tend to be more common, and the ratio is actually 10 to 1. And the best prognosis is given when these injuries are detected early and when they're treated early. So 9 out of 10 patients, they have penetrating esophageal trauma. Sorry, with penetrating esophageal trauma, they have major associated findings. So it's also good to be on the lookout for associated injuries in patients with esophageal tears. So for the imaging modalities, we have these four main imaging modalities. We know plain radiographs are the ones that are easily accessible. That's usually the first line imaging modality that we have. However, with these plain radiographs, we'll only be looking at indirect signs because it cannot show us where exactly the esophageal tear is. But now that's where the esophagograms come into play, because with contrast, you're able to tell the exact location of the esophageal tear. So CT scan is even better than the esophagogram, and it's even recommended when the esophagogram is negative. And then to a lesser extent, you can use MRI. So for the pathogenesis, we know initially the main event is injury with perforation. With that, you have a transmural disruption. And then what follows that is leakage of the intraluminal contents into the mediastinum. And then that's what will kickstart the process of inflammation, infection. Initially, the infection will be localized, and then it can cause mediastinitis. And if it gets disseminated, you can get sepsis and subsequent morbidity and mortality if it's persistent. So in a few patients, they present with a Makla's triad. That is 1 out of 7 cases. And Makla's triad is just a cluster of symptoms that include subcutaneous emphysema, chest pain, and vomiting. So this is like the classical triad in esophageal tears, but it's not seen in a majority of the cases. So we'll start with plain radiographs in esophageal tears. It's usually positive in 80 to 90% of the cases. The image to the left is just the normal anatomy when you're looking at a frontal radiograph of the chest. So if we start with the upper and the mid esophageal perforations, we said the commonly injured areas is cervical esophagus. So it goes without saying that it's the upper and the mid esophageal perforation that tend to be common. And we've said of all cases, Of most cases, it tends to be iatrogenic. So some of the signs that we'll be able to pick out on radiography include widening of the pre-cervical soft tissues, and this will be best appreciated on a lateral radiograph. The widening of the pre-cervical soft tissues. You can also have air in the pre-cervical soft tissues and widening of the superior mediastinum, which you've seen how a wider mediastinum looks like, with a right-sided hydrothorax. So in this next radiograph, we're looking at a frontal radiograph of the chest, and it's showing one of the signs that I've already mentioned. So could someone describe the positive finding in this image?
Diana?
Okay. We are able to see that I think the mediastinum is widened. We're not able to see the cardiac outline on the right as well. And there is, I think, an effusion on the right.
Yes, we're able to see a right-sided hydrothorax.
Mm.
So these right-sided hydrothorax, they're commonly seen when it's the upper and the mid esophagus, because we said as you move from the superior to the inferior aspect of the esophagus, initially it's just anterior to the vertebra, then lower within the thorax, it veers to the left before passing through the diaphragm. So when the injury affects the upper and the mid portion, you expect to have hydrothoraces on the right side.
Shows all those areas. Go back. Air
Yes.
in the pre-cervical soft tissues.
Okay, now in this, we cannot see air in the pre-cervical soft tissue, but in the next radiographs, that's what I wanted to
If
illustrate.
you look at the SVC shadow, and then you go more, yes, that is air. There's some air tracking up there.
All right. Okay, thank you.
Not along it, it's within the mediastinum. Just outlining the structures within the mediastinum. Yes, you don't expect
All,
to see it. Yeah.
okay, thank you.
The other one could be the Mach effect. Okay.
All right. So in this next image, we have a lateral radiograph of the cervical spine. And what we can see as pointed at by this blue arrow is air within the precervical soft tissues. So this patient later on had an NGT put in place, and posterior to it, we can confirm that this pocket of air is not within the esophagus, and it's actually within the precervical soft tissues. And you can also note thickening of the same precervical soft tissue. So these are all the signs that we've mentioned. So how we also try to determine the normal thickness of the precervical soft tissues, we say that before from C1 to C4, the precervical soft tissue should be less than a third of the vertebral body, and then lower than C4, it should be no greater than the body of, of the cervical vertebrae. So we can clearly see that there's thickening of the precervical soft tissues. So next, so we've covered upper and mid. Next, we'll move to lower esophageal perforations. So here we'll be looking mostly at Bohave ruptures, which usually occur in the left inferior posterolateral wall of the esophagus. And on a radiograph, here we'll be looking at indirect signs. And these indirect signs include pneumomediastinum. And you've already seen how some of this, how pneumomediastinum appears on plain radiographs, but we'll look at that in the next slide. You'll also have left-sided pneumothorax because of the location of that here. You'll also have pleural effusions. They're striking particularly on the left, and they're often associated with left lower lobe consolidation. You'll also have a hydropneumothorax, so you can have fluid and air. And then you can have plain hydrothorax. You can have pneumomediastinal air along the inferior descending aorta, which you've seen. You can also have air in the left cardiovertebral angle, of the diaphragm, and it forms that V sign of Naegleria. And also you can have a subcutaneous emphysema in the neck and mediastinal widening, especially when mediastinitis has set in. So the image on the left is a fluoroscopic examination. In this case, you're looking at a barium meal, and you can see the esophagus is well outlined. And on the inferior aspect, right above, or rather where it makes the transition into the abdominal part, you can see extravasation of contrast with a lucency around it. And this is suggestive of a Bohab rupture. So the
I
same
have a
patient,
question about that. Huh?
yes.
Why is it not hiatus hernia?
I'd put that as a differential, but
Mm-hmm.
the thing that would make me not think of it as a hiatus hernia is this lucency, the air around it.
Now, the air around it will definitely point towards a rupture in terms of air tracking, but I'm just wondering why this contrast is so well contained until you almost think you are seeing a mucosal fold or a cleft on its medial
Yes.
aspect. Yes, yeah. So you're right, it to be a differential. What do you think about the esophagus, the rest of the esophagus?
Okay, it is
What does it
wavy.
have? Yes, what is that? What does that mean?
Peristalsis, I just took it to be peristaltic waves.
Yeah. These are abnormal peristaltic waves. They're known
Oh,
as tertiary contractions, and you tend to see these more in elderly people.
okay.
Yeah, just a normal, well, you can call it a normal variant, something that is fairly common in elderly people. Yeah.
Oh, all right, thank you. So this is the same patient with Bohab syndrome. And in this coronal reformat, we can see there's extravasation of contrast into the into the right hemithorax. Yeah. So this is also indicative of an esophageal tear. This patient was given oral contrast. So in this next radiograph, we can pick a couple of signs also. So in this frontal radiograph, AP, we can see there's an obvious fluid level in the left hemithorax, and there's complete lucency of the entire left lung field, and you can see a mediastinal shift to the contralateral side. So this is also indicative of rupture of the esophagus with fluid and air occupying that lung field.
It's not lung filled. That, what else would you use? Hemithorax, isn't it, right? The lung is
Hemithorax.
completely collapsed. You can see it
Mhm.
against the mediastinum, that triangle that you're seeing going all the
Yes.
way up to the
Okay.
hilum. No, well, yeah, to the hilum. Actually, below that, there's another sharper line. Yes, that one. That's a collapsed lung. Yeah. So you have air filling that hemithorax with an air fluid level. What's happening in the contra? And there's a mediastinal shift. That's important to mention because it
Yes.
means it's under tension. And what's happening in the right lung?
There's some opacity in the right upper lung zone,
In
but
the
they
right
didn't
upper zone, you don't add lung. In the right upper zone,
in the
yes.
right upper zone,
Mm,
but they didn't report it as any pathology.
but you can report it now.
Yes. Mm,
What do you think is going on? Or you can always call a colleague to look at it. It has,
yes.
yeah, Taleni?
It looks like there's a visible pleural line
Mhm.
there in the right upper. Yeah, in the eighth. Yeah, there's a visible pleural line.
Where Taleni? I'm seeing a rib.
So like Sharon, go up, like just on above the clavicle.
Mm-hmm.
Yes,
That's a
there.
rib. That's a posterior rib, rib 3.
Oh,
But it's
are the
opacified
lung markings
beyond it.
beyond?
Well, I don't quite see them, but the line you're talking about is a red.
But what I'm thinking more is you can see it's opacified, there are air bronchograms, and it's limited by the horizontal fission, which is elevated. So it looks like there's partial atelectasis, and even that hilum is at a higher level than it should be. Yeah. Yeah.
Okay.
Yeah. But I think one has to. The markings above that rib are not very clearly seen, but I'm not really seeing a pleural line, even with expansion. Yeah.
All
Trying to
right.
explain the image. Yeah. Mm-hmm.
Okay, thank you.
Yeah.
Then this is the V sign. So this V sign is formed by air, mediastinal air, and that's air outlining the descending aorta, and it intersects the air that's over the left hemidiaphragm. So at this area, it forms that V sign.
Then in this next image, we can still note mediastinal air, and we can still see it outlining the descending thoracic aorta and also overlying the left hemidiaphragm. So this next case is a case of a 72-year-old woman who presented with emesis and chest pain after an esophagogastroduodenoscopy. Dilatation was done. So in images C and D, we can see this is an esophagogram and it's outlining the normal esophagus, but we can see contrast collecting like almost midway through the esophagus. So it's extravasating and collecting just lateral to it. And the same can be appreciated on also this other view. So on the CT of the same patient, they were able to localize better the area of the esophageal tear. We can still see contrast extravasation as indicated by this black arrow. And on the axial cuts, they were able to also note air locules external to the esophagus. So on endoscopy, they were able to much more specifically pick the area that had the esophageal tear. So this is another case of a 74-year-old man who presented with retching and hematemesis after eating. So first, they did an esophagogram, which showed a normal appearing esophagus from superior to the inferior extent. However, because of the high index of suspicion of the possibility of an esophageal tear, they did a CT scan. And from the CT scan, they were able to note air locules within the wall of the esophagus and also externally on the anterior and on the right of it. So on the same patient, CT, axial CT, lung window, they were also able to illustrate further the collection of air around the esophagus, especially when the injuries are quite small. The best imaging modality that is more sensitive is a CT scan, and you can see it's able to illustrate all that. In the sagittal cut of the same patient, they're able to show the superior and inferior extents of the collection of air anterior to the esophageal wall. So all of these are signs that we've already looked at.
If you go back, the air is tracking within the esophageal wall, isn't it?
Within, all right?
I thought so. What, the black arrow? Some of it is definitely within the mediastinum, but some of it is tracking within the wall.
Yes, that's true. Yeah, I think it was even very clear on this one. Yeah, it's within the wall, and then our summer external. All right. So since we've gone through the sign of pneumomediastinum, and the answers are to the left of the screen, then we can mention as I go through the images. So what can we see on the radiograph on the right?
Derek?
Yeah. What we can see is on the lateral radiograph is air column anterior to the pericardium, all the way from the left cardiac border to the mediastinum. That will be pneumopericardium.
All right, that's true.
Yeah, because wait a minute. Okay, yeah, because the pericardium usually goes way up, way up to the root of aorta. But doc, before we continue, I had a question. There's an
The
image.
pericardium goes way up to where?
No, the pericardium usually goes up to actually the the, um, the root of the branches of aorta, and it's actually usually a potential site where the pericardium can be injured, especially in some procedures like SVC insertion, etc. So that's usually just a
Any other question?
yeah. There was a previous image I wanted to ask a question. Maybe Doc, if I take you back just a minute.
Okay. I scroll backwards.
Yes, I will tell you the image. That one, this one. Okay, there's a chest X-ray. There's a chest X-ray. Just until this one, yeah. You had said which view was this? Because I had AP.
Yes, AP.
Okay. So for me, I was thinking it was a PA. It's a discussion we're having today, like how to differentiate the AP and PA. I would look at the clavicles and the medial ends of the scapula. But now, most importantly, as much as we were mentioning the findings, especially on the right upper lobe, I was thinking there was some element of rotation for these patients, more to the right, rotation to the right. So maybe I would also maybe ask Doc for guidance at this point. At how can you quantify the significance of a rotation in a chest X-ray so that it doesn't impact on our pathology interpretation? Thank you.
That was a good pick. Yeah, there's quite a bit of significant rotation here, and I agree. This is a PA. It's
PA.
not an AP. Yeah, it's a PA because the scapulae actually away, and the heart is not enlarged.
Yes.
Yeah, though I must admit, I'm not. And there's an airfluid level. Well, anyway, there's an airfluid that can also be a sitting up AP, but I think it's a PA. So, how do you tell about the significance about the shift? Normally, I look at the heart and see how much it is on both sides of the spine, because if there's rotation, I'd expect the heart to also rotate similarly. Yeah.
And just to follow up on that question, we've said here there's mediastinal shift to the right side.
Yes, I
And
said there's a personal shift.
can we still comment on that despite having this amount of rotation?
I personally would still think about this mediastinal shift. And
All
I'll
right.
need to figure out why. Because I'd rather talk about there being mediastinal shift than miss it absolutely altogether. Yeah.
All right. True.
Because despite the slight atelectasis of the right upper lobe, it still doesn't explain why we have still more of the heart on the right side. And the other thing one would look at would be the relative difference in the lung field. But here, of course, because of the pneumothorax, you can't again use that to rely to see how significant is this shift. Huh? Yeah.
True.
I
So,
think
I think, do you have an answer?
no. I was just thinking maybe it's
Mhm.
important for us usually to also comment on these technical issues because it will actually supersede our interpretation of some of the structure of the findings we
Oh,
have.
yes. That is actually important, and actually point towards the limitations of the image that you're reporting on. It kind of like covers you in case you make any misdiagnosis, or it helps. Yes, when it is a medical legal issue and that sort of thing. So it is actually it is important. Actually, that's what's supposed to be done.
Yes. For this image, before we proceed to the next one, so from the text, they said in pneumomediastinum you'll have gas anterior to the pericardium, and then there's a term pneumopericardium. I was of the opinion that pneumopericardium is air within the pericardium itself and not anterior to it. So now, is this pneumopericardium or is this air anterior to the pericardium?
It's pneumopericardium because it's within the pericardial sac. But I think in a radiograph, it may be very hard sometimes to see that thin line of the pericardium, and therefore just looks like gas anterior to the cardiac shadow, isn't it? Huh? I think it's a descriptive how, yeah, somebody just wrote it that way. But I think if you think about it, it's pneumo within the pericardium.
And there are some images you can actually see the parietal wall of the pericardium and air, and the visceral, that kind of thing.
Yes.
It will not be clearly seen in this particular image. Yeah.
All right. Thank you. So this is the next radiograph, and the white arrows are pointing to a sign that we've already talked about. Can someone mention it?
Yeah, go ahead, Sada.
Would that be the ring around the artery sign, the one in white arrows?
Yes, yes. Then these other yellow arrows are pointing to air over the right hemidiaphragm on the medial aspect, and the one on the left heart border is also pointing towards air outlining that left heart border. Then this is another radiograph showing tubular artery sign. And in this case, you have air outlining the major branches of the aortic arch. In this case, we can clearly outline this vessel going upwards in this direction. This I'd call it the left common carotid. Then this next sign, we've also seen it before. Can someone mention what it is?
Double.
bronchial wall sign. Yes, double bronchial wall sign. And then this blue arrow is also pointing to a sign that we talked about. What is the sign?
Continuous diaphragm sign.
Yes, continuous diaphragm sign. And this is the same patient in the lateral view. It shows air beneath the, still in the continuous diaphragm sign, but now air beneath the heart over the diaphragm. Then we have at the extrapleural side. So here we have air from the mediastinum extending laterally between the parietal pleura and the diaphragm to produce that extrapleural sign. So it's air outlying this descending aorta and also air overlying the left hemidiaphragm. The Clarios V sign, we've already mentioned this. And this is where you have these two lines intersecting over the left hemidiaphragm. So this lucent line and the air also from outlining the descending aorta. So all these are signs of pneumomediastinum. So that's all I had for esophageal tears.
Just go back a bit.
How did you see the continuous diaphragm sign? Okay, fine. Yeah, it's okay. I just need to revise what's in my mind. Okay, let's continue.
Yeah, about the esophageal tears. Yeah, I was just trying to reason. Okay, I know like there have been many images posted about that recurrent esophageal dilatation. Okay, for me, I think I don't know if it's really strictures, but there are usually also patients who present with achalasia cardia. But now my question was like to the class, and yeah, and I was like, how frequent should we be doing the esophagograms as opposed to the endoscopies? Or maybe how practical is the situation?
In terms of detecting esophageal tears.
Yeah.
The question you're asking is when a patient presents with chest trauma and you're suspecting there's mediastinal injury, how would you manage that patient? Would you take them for imaging or would you take them straight for endoscopy? What do you think?
I think I'll take them straight to imaging.
Yeah. I think you'll do an imaging first. So you'll do, yeah, and most likely, remember, we tend to do CT scan in most cases when you're thinking of all this traumatic, especially when it comes to chest trauma. Apart from when you're thinking of ribs, when you may be thinking of the a chest X-ray and all that sort of thing. But when you suspect that there could be mediastinal injury, you're going to do a CT chest. And then from there is when now you can decide what will be the next course of action. And you can see from the pneumo, if there's the way the pneumomediastinum looks like, then they can go ahead and do the endoscopy with a view to how they will manage that patient.
Are esophagograms still widely done today? Like when can we think to do it?
We would rarely do an esophagram for a traumatic esophageal tear nowadays, really, especially when it is due to a road traffic accident. We don't really have that many fluoroscopic units available, even within Nairobi. There are really very few hospitals that have them. I think right now I can just think it's probably Aga Khan, KU, and Gertrude that has it. And Nairobi, maybe in the private sector, they might be having that. But the requests also for doing barium swallows or contrast are really not there that much. You definitely would do a CT, which will give you a little bit more information. If you still think there could be a problem with the esophagus, you can even still give them a non-ionic contrast media to swallow in case they aspirate, and can still quite outline either any leaks or anything like that. Any fistula, you'll be able to pick them up quite well.
Okay, thank you.
Yeah. I think a little earlier on, maybe by the time I was training, we used to do a little bit more of these esophagograms, actually. But nowadays, we rarely do them. Now, if a patient is maybe vomiting blood, they're more likely to go straight for endoscopy than actually bring them to radiology. Because I think that is more of an emergency situation. Yeah.
Sure. Before I proceed to the next topic, I have a question, or rather an observation. We came across this continuous diaphragm sign also when you were talking about pneumoperitoneum, if I'm not wrong.
When air is outlining the diaphragm
Yes,
from
it
below.
happens in both of them. It happens in both of them. And I agree, Taleni, it doesn't have to be completely continuous. You can have a gap in the middle. Because really on the right side, the diaphragm should really end at the right cardiophrenic border. And you can see it's going beyond.
Yes.
Mm.
So next we look at diaphragmatic injuries. So we know the diaphragm is a flat muscle and it separates the thorax from the abdomen. So of all traumatic injuries, diaphragmatic injuries are they have a prevalence of 1%. of all traumatic injuries. And from Harris and Harris, they say 66% of the traumatic diaphragmatic injuries are as a result of blunt force trauma. Of the side that's affected between the right and the left hemidiaphragm, it's the left hemidiaphragm that's most commonly affected, up to 67%. And 70% of the cases tend to be picked on the initial chest X-ray images. So it's quite important to still go with that as the initial imaging modality. So it is also recommended that when you're doing that chest X-ray, that you take it when the patient is supine and when they have an NGT in situ, and we will see why. So the imaging modality that's still the most sensitive is an MRI, but also a CT scan can pick up that pathology quite well. So in an alternative reference, this is NIH, an article that I've linked in the notes section on this specific slide. They say that penetrating trauma accounts for 2/3 of the etiologies of these diaphragmatic injuries, commonly having stabs followed by gunshots, and then the remaining third being attributed to blunt trauma, and majority of those being as a result of road traffic accidents. Still remains that it's the left side of the diaphragm that's injured more, and it affects males more at a median age of 31 years. And these blunt injuries, despite them being less common, they have a higher severity score and they have a higher mortality rate. So over 50% of diaphragmatic injuries, they have associated injuries. So it's good to also be on the lookout for that. And mortality from delayed presentation is around 20%, which means that a majority of these diaphragmatic injuries are caught early. So that's a good thing.
I have a question. Are you going to discuss why MRIs are more sensitive?
I don't have the MRI. I don't have MRIs for this. I only have CT and X-ray.
But you got this from somewhere. Did they explain why they think MRIs are more sensitive?
I
Because
got
you
it from
don't use MRI in acute cases or in trauma, really.
I got this from Harris. I don't think they explained, but I can check again.
Okay, that's
Yeah.
fine.
So chest radiographs, they're diagnostic in, you said, in around 60 to 70%. And some of the features that we'll be able to see is the inability to trace the normal outline of the hemidiaphragm contour. You can also be able to see intrathoracic herniation of hollow viscous, especially if you're looking at the left side, with or without a collar sign. We'll see what the collar sign is. You might also be able to have, might be able to see a contralateral shift of the mediastinum if the herniated component is large. You may also be able to visualize the nasogastric tube. You'd expect it to be in the stomach below the diaphragm, but in this case, if there's herniation of viscous, you see the nasogastric tube above the hemidiaphragm. And then you can also be able to see a left hemidiaphragm that is much higher than that on the right. So the image to the right of the screen is a barium follow-through. And what we can see this herniated stomach above, within the left hemithorax. And we can see its lower part is narrowed. And then we can appreciate the rest of the remaining contrast. Contrast has passed through the remaining bowel distal to it. So this narrowing is what they term as the collar sign. In better imaging modality, it forms an hourglass figure. So like in this, here we also have another follow through. And in this study, we can see a hollow viscous that has herniated through the left hemithorax. We can see an air fluid level. And just before we get to the waist of this structure, we can see contrast above and below it. And then you can see contrast in the distal bowel. So this is the collar sign or the hourglass sign. So that just goes to show that there's a diaphragmatic rupture in that area, and hollow viscous has gone through it into the left hemithorax.
What is that distal bowel that is being shown?
This? This is the duodenum.
Any other offers? You look at the previous image.
Descending colon.
It's a splenic. Yeah, look at the previous image. Just look at the previous image. Now you can see what the jejunum looks like, huh? And the duodenum. That
yes.
pattern, the mucosal pattern. Yes. So it is colon, the next image. So you have the transverse and the splenic flexure. It's a quite a delayed image of a barium meal follow through. So there was hold up in the stomach.
Yes. Oh, yes, because I was wondering, okay, this is the bowel that's coming immediately after the stomach, so I was expecting it to be duodenum or jejunum, but definitely it has features of being the colon, transverse and sigmoid and descending.
No, yes, transverse and splenic.
Or transverse and splenic.
Yes, we are in the left upper quadrant.
All right. Thank you. So in this next radiograph, what we can note is that we have this round lucency in the left hemithorax. It is outlined by this
opaque line around it, and there's obvious, we cannot make out the left hemidiaphragm. So in this same patient, they did a lateral radiograph and they're able to appreciate the same round lucent structure that is well outlined by this opaque band. And we can also see that we cannot appreciate the cardiac shadow quite well. And I took that to mean that it's the left side of the thorax that's affected. So in this case, we have a patient who has a herniated stomach into the left hemithorax. So next, we look at the CT features.
And bowel, and even in the frontal image, you can see the mediastinum is pushed
Quite towards the right, huh?
Yes.
Yeah. And then the lateral confirms that quite well.
Yes. Thank you. So next, we look at the CT features. So some of the features that we'll be able to appreciate on a CT chest in a patient who has diaphragmatic rupture include you may be able to see a direct discontinuity of the hemidiaphragm with or without herniation of viscous. So that is in subtle tears. You may also be able to pick the same collar sign or hourglass sign that we've seen on the radiographs. You can also pick a dependent viscera sign. In this case, when the patient is lying supine and there's a ruptured diaphragm, the viscera will tend to want to move towards the dependent area within the thorax. So it has a higher tendency of herniating through the ruptured area when the patient is supine. So this can be picked on a CT chest. Chest and abdomen, and then we might also be able to pick segmental non-recognition of the diaphragm when it's ruptured. We'll also be able to see focal thickening of the diaphragm adjacent to the area that's ruptured. We'll see that. And you can also pick thoracic fluids abutting the abdominal viscera and other indirect signs like a hemothorax and a hemoperitoneum, which are not so specific. So in the image to the right, we have an axial CT, mediastinal window. And what we can note in the left hemithorax is that we have this atelectatic lung. And in the sagittal, we can make out the same lung that is atelectatic. And then right below it, we have the stomach. And we can see this stomach is not confined by the hemidiaphragm. As a matter of fact, this is a hemidiaphragm that appears thickened and there's an abrupt end to it. And its corresponding part is this posterior part, which is totally separated from, you can see the gap is quite big. And we have all this herniated viscous. So this is just an annotated image That's illustrating the scene. So these red lines are where you expect to, that is where we have the diaphragm. So if we move more towards the right side, so in this case, the patient had a mediastinal shift to the right. Towards that side, you can make out the entire length of the diaphragm. So ideally, it should appear this continuous. So if you compare this with this other one, we can definitely see that there's a cutoff, and we can see thickening at that region of the diaphragm that's affected. So next, we also we have this coronal reformant, and it's post-contrast in the portovenous phase. And what you can see here is a dependent visceral sign. So we have a ruptured left hemidiaphragm. We can see this portion of the diaphragm that is thickened, and then immediately medial to it, we can see the stomach that is herniated into the left hemithorax. We cannot appreciate very well the medial aspect of the left hemidiaphragm here. In this next CT scan, we have a ruptured right hemithorax, hemidiaphragm, and in this case, you can see herniated right lobe of the liver into the right hemithorax. So this
And
is
actually, that one, you also get a collar sign on that liver.
oh,
There's a bit
yes.
of a waste there. Yeah.
All right. Thank you. So in these next images, we have a sagittal CT, and then we have a coronal CT reformat of the same patient. And what they're indicating by these arrows is a dangling diaphragm sign that shows an abrupt cutoff of the diaphragm and a thickened diaphragm adjacent to the area of the rupture. So this also points towards a ruptured diaphragm, especially when you don't have that dependent visceral sign that is obvious. In this next axial CT, we can also, if we follow the diaphragm, the left hemidiaphragm, anterior to the spleen, we can see that there is an obvious defect in the diaphragm anteriorly, and we can see focal thickening in the adjacent areas of the diaphragm. So it can be subtle or it can be very obvious with the hourglass sign and the dependent visceral sign. So this is a case that Taleni and I had to report over the weekend when you were on call. So it's a case of a gunshot injury to a patient. He was shot on the left hypochondrium, and the bullet exited on the right posterior back. So from this, we were also able to pick a diaphragmatic rupture. First, I'll just let it play, then I'll go back to the area of injury. So that's all of it. Then I'll go back to where we saw the focal area of diaphragmatic rupture, and this is that area. So the bullet entered from this side, the left side, and the trajectory is from the left to the right posteriorly. So if you look at the left cruise of the diaphragm, we can see a clear break in the continuity of the left cruise of the diaphragm, and you have that nodular thickening of the diaphragm. So that's it for diaphragmatic injuries. Are there any questions before I proceed to the next? Yes?
Yes, Daktari, thank you for highlighting that case. What would you advise the cardiothoracic residents who wanted you maybe to say something about the aorta? I hope you picked something.
Yes, there was a filling defect from this. I don't know how exactly they manage it, but we pointed it out.
So yeah, about that filling defect. Now, I was trying to figure out how did it arrive, because from the 3D recon images, was there anything maybe extraluminal, or was it just involving that adventitia? I don't know.
I don't know about that unless I inquire more about the case, but from the
I hope
3D report,
Sorry for it. I have the 3D recon I'll send to the class. Yes, you can see. So in the 3D, you could see how the outer, the posterior part of it being a bit injured. So it was better demonstrated on 3D.
Yes, it was showing the external part of the aorta that was affected. That's true. And there was also some feeding defect on the internal part. But also for this specific case, for the diaphragmatic injury, I just wanted to illustrate that when it's not so obvious and you don't have a dependent visceral sign, like you don't have the liver or the stomach herniating through the diaphragm, it's important to try to follow the outline of the diaphragm and look for any obvious gaps. And when there's a gap in the continuity of the diaphragm and it's nodular, then you know that there's an interruption there. Yes.
What about the spine?
Yes. So for this case, yeah.
That was also spine.
So I can outline all the findings that we saw. So if I'm to start with where the entry wound is, there was some air locules within the soft tissues, and then on the posterior aspect of the stomach wall, there's a break in the continuity of the stomach wall itself. And then also we noted that the gastric contents, they are more dense towards this posterior aspect, and that is what made us also think more towards a ruptured posterior wall of the stomach. And then the adjacent diaphragm, there's some air locules within this part, better seen on other windows. And then there was an obvious break in the diaphragm on this aspect. There's a burst fracture. I don't know if you should call it a burst fracture, but the vertebral body was totally shattered. Then in the adjacent aorta, we can note that there's a filling defect. I don't know if this probably would be an outside-in injury to the aorta. And then we had fracture fragments within the spinal canal. And then the pedicle on this side, the pedicle, the transverse process, and the lamina was also comminuted, and there were also some air locules where the exit wound was. So we had a cluster of findings in this specific
Yeah,
patient.
the patient was quite injured. Huh?
Yes.
The spinal canal was reduced, markedly reduced inside. So the cord most likely was also injured. And this is a patient who would require an MRI. The injury to the aorta was intramural, right? As opposed to a rupture. Yeah,
All
that
right.
looks like a wall hematoma.
Mm-hmm.
And even for the stomach, I thought there was bleeding into the intraluminal, a little bit more intraluminal than extraluminal in the stomach. Yeah. But it kind of like looked a bit also contained around the stomach. Yeah. Do
True.
you know how the patient is doing?
I don't know. I've not seen him since Saturday.
Oh, okay.
We've not yet followed up.
Shot within Nairobi?
Yes, shot within Nairobi in town. He was walking when he got shot. That's the history they gave us.
Okay. You can proceed.
All right. So next I'll move to airway foreign bodies. So airway foreign body. So this is commonly seen in the pediatric population, and they commonly tend to the foreign bodies that they tend to aspirate into the airways of food, teeth, and small toys. And of the food they aspirate, we are looking mostly at organic material such as seeds and nuts. So with that, it goes without saying that if they aspirate this foreign bodies into their airways, when you do a plain radiograph, because they are not radio opaque, you will not expect to see them. So you really need to be keen to look for indirect signs that will point towards aspiration of these foreign bodies. So of the children who are mostly affected, it's predominantly male. And the aspirated objects have a predilection for the right tracheobronchial tree because it's short and it's more vertically oriented and it's wider. Yes, so they have a typical history when they present to the hospital. Usually, you can have someone who has witnessed them aspirating the foreign object itself, and they have that cough that follows it. So, radiographic features, the hallmark sign is that you want to demonstrate a lung volume that does not change during the respiratory cycle. And because of that reason, there's a dedicated suspected foreign body inhalational series of radiographs that can be taken to illustrate that specific sign. So before we get to the dedicated series, we can first look at AP supine radiographs that have some of these indirect signs that we've talked about. So could anyone point to the sign that we see in this radiograph?
Orlando?
Doc is doing the call.
Okay, go ahead then.
So we are presented with an AP supine AP chest radiograph, not covering the whole abdomen, so it's not a babygram. And what we can see is increased radiolucency of the left lung field as comparative to the right. That's obvious. I don't know if Doc can zoom in. The trachea seems to be, the trachea is centrally positioned. And sorry?
No, I'm saying I can also help you by saying that there's no foreign body that can be visualized within the airways, yeah? And the direct sign is this lucent left hemithorax, yeah? Comparison to the right. So the case is of a child who was eating almonds and they started choking. So they suspected aspiration, and on bronchoscopy, which is the gold standard, they were able to aspirate the almond piece that was choking the patient. Then in this next set of images, we have a frontal and a lateral radiograph of the chest. So in the frontal radiograph, what you can see is that there's opacification of the left upper lung zone. Yes, that is silhouetting the descending aorta, but just the aortic arch.
There's opacification at the left upper and mid zone with silhouetting of the left cardiac border. What is happening at the aorta? It's not silhouetted.
Oh, yes. It's not silhouetted. So this goes to show that it's the
No,
left.
I need to tell me the sign, or somebody in the class can tell me what the sign is. Because I think we covered this.
Yes, we covered the silhouetting of the left heart border.
Yes,
The
but let's
pathology.
go to the aorta. Anyone? Any offers? Talene. Why we see it more clearly? The arch of the aortic knuckle.
There's air around it. There's air outlining it.
Yes, why?
Pneumomediastinum.
No. So
Compensatory
there's
lobe.
air. Remember, if there's collapse of one lobe, what happens to the other lobe?
Or it will hyperinflate.
It will hyperinflate. And
Yes.
so which lobe is next to the aortic knuckle? It's the lower lobe. Huh?
The lower lobe.
Yeah. So do you remember the sign? It's a German word.
Merkel's? No.
It starts with an L.
Luftstelle.
That's the sign, right? What other sign do you see? All the signs actually here. And I thought we didn't do collapsed lung with you guys?
No.
Not yet. Okay. Then what's happened to the diaphragm and that tenting and all? There are several signs here.
Yes.
Elevation.
Rooted.
Yes. Yeah. Okay. We can proceed. And then again, you can now see it also very clearly in the lateral view. Eh?
Yes.
Yeah. So that's characteristic of left upper lobe collapse.
Yes. So we have reduced volume of the left upper lobe, and you can see that opacification is limited by the major fissure. And then there's that compensatory hyperinflation of the inferior lobe. All right. So in this next set of radiographs, we have a case where we have right middle and lower lobe collapse. So in image A, we can see there's opacification of the right lower lung zone with a silhouetting of the right heart border and the hemidiaphragm. So in this case, that's why we will say that it's a right middle and a right lower lobe collapse. And then we have compensatory hyperinflation of the right upper lobe. Yes, and that is what they've pointed at by these arrowheads. So in the lateral view, we can still see that the opacified lung region is on the right side because it's not silhouetting the cardiac border. And that's what they're illustrating by these arrowheads. It's seen cutting across the, the heart shadow.
Well, how do you know that the problem is on the right side in that lateral view?
In this lateral view, yes, I know it's on the right side because this line, the opacified region within the lung, it we can see that opacity going over the lung anteriorly. So it's
So
not
there
silhouetted.
is a hemidiaphragm that is silhouetted. Which one is silhouetted? You showed us in the frontal radiograph, in the PA, the hemidiaphragm which was silhouetted, which is the right. Can you see the right
Yeah.
hemidiaphragm here?
No, I cannot see the right here.
Yeah, so it's again, it still confirms, right? So, and one on the right hemidiaphragm goes right from anterior to posterior. It's complete, as opposed to the left, which will be associated with the gastric bubble, and it stops just where it reaches to the heart. Huh? It's not
Yes.
usually complete. Yeah.
All
So
right.
again, that also confirms to you that again, you have a right lobar collapse. Huh?
Yes.
And then the opacification overlying the heart tells you the middle lobe is involved.
Yes. All right. Thank you. Then now we look specifically into the foreign body inhalational series. And in this series of images, what we'll need are these three views, of which the third has two views. So first, you want a frontal radiograph that is inspiratory. Then second, a frontal radiograph that's expiratory. In both of these, you want to look at the volume of the lung and whether it's changing or not. And in this case, the one that has the obstructing foreign body, it will not change. Then you want to get a bilateral lateral decubitous views to illustrate that change in that there's no change in volume. So in the image to the right, we have an AP supine, and in this case, we can see a lucent right hemithorax with a mediastinal shift to the contralateral side, and the left hemithorax looks normal. So in this patient, they did a lateral.
Let's go back. Let's go back. So this radiograph, it's in what phase?
In terms of spirit. Okay, let me see one. This is in inspiration.
Any other offers? It has to be the other phase, isn't it? Remember, the normal side is which side? It's opacified side, huh?
Yes.
the child will come with a characteristic history. Maybe they were playing, or they began wheezing suddenly, or just have a sudden onset of a wheeze or dyspnea, or that sort of thing. So you do an inspiratory radiograph, and the lungs might look the same, or there may be increased radiolucency of one side. Then you do the expiratory. So you have the normal lung collapsing, getting more pacified, and that now confirms that the problem is now on the lung that does not change in volume. We really need to do the decubitous views, because you also have to think about ALARA. I mean, if you can, so normally inspiratory and expiratory views tends to be adequate.
Yeah. All right. All right, for the same patient, they did a lateral C-spine radiograph, and they were able to note all this subcutaneous emphysema that's anterior to the neck and also overlying the sternum. And then when they did the decubitus views with the left dependent side, if we compare this left versus the right, we can see that there's no change in the right in the volume of the right hemithorax. And also, if you turn your attention to looking at the right cardiac margin, you can see that it does not shift in either of this. So it shows that the obstructing foreign body is within the right main bronchus. So next, we look at CTs. So CTs are more sensitive than chest radiographs, and that's because it will show you where the foreign body is exactly within the respiratory tree. And yes?
Is it because of air trapping that the side with the obstruction is more lucent compared to the healthy side?
Yes, it's air trapping. You have a ball valve effect. So air can get into the lung but cannot leave it because of the foreign body. Yes. Yeah.
Yes.
Did you find the decubitus views very clear?
Not really.
Sharon, make a point for your decubitus views.
Okay, so let me go through.
Yes, go ahead.
Yes, so okay, so in the supine, we already identified it's the right hemithorax that has the pathology.
Expiratory, in the supine expiratory.
Sorry, supine expiratory. Then, when we did the lateral decubitus, so on the left dependent, if you look at the right hemithorax, you can just appreciate the lung volume in comparison to the opposite side. And I said, if you turn your attention to the right heart border, you can see it's medial to the lateral aspect of the vertebral bodies. It's to the left.
The thing is the volume of the right lung did not change.
Yeah.
Yeah, because in the left dependent, it was much more clearly seen because the left lung was more contracted, had a low volume, big. So you can see the right lung remains expanded. But when you do now a right dependent, it becomes really not clear because they more or less have a similar opacification. The only thing is that the cardiac shadow seems to be displaced a little bit more towards the left. Why is there a continuous diaphragm sign in all these dependent images?
The possibility there could be an pneumomediastinum.
Yes, Diana?
Even in the first expiratory phase imaging, there is mediastinum. You can see there's air along the cardiac border on the left.
Along the cardiac border. What you have is there's air tracking from the mediastinum going into the neck. You can see that, huh?
Yes.
No, in this expiratory, yes. But you don't see that continuous diaphragm sign, but there is a pneumomediastinum. I do agree, even in these images, right? You can see that, right? That those vertical lucent bands. But Your lateral view again confirms that there was air within the neck, lateral view. The lateral neck view.
Sorry, this.
Yes. And you can see it extends to the mediastinum, yes.
Sure.
And that also explains what we are seeing in the decupitous images. Huh?
Yes. All right, thank you.
Okay.
So yes, so we mentioned that CTs are more sensitive because they can pick the foreign body within the bronchial tree, whether it's radiolucent or not, or rather radiolucent or radiopaque. So what's illustrated on the image to the right, we have an axial CT of the chest, and we can clearly visualize the foreign body within the trachea. And on the coronal reformat, we're also able to pick the same foreign body. So other than radiography and CT scans, bronchoscopy still remains to be the gold standard of diagnosis, and it's both diagnostic and therapeutic because you can remove that foreign body. So lastly, the next topic we'll cover is aspiration pneumonia. So by definition, aspiration is the intake of solid or liquid materials into the airways, and it can occur as a result of many things. So in adults, it's commonly seen in alcoholics because they tend to aspirate their vomit a lot. It can also be seen in GA because of an impaired gag reflex, and also post-op if you add the fact that patients can develop ileus that can further worsen the probability of aspiration happening. In individuals who have loss of consciousness, also because of that impaired gag reflex. When you have structural abnormalities of the pharynx and the esophagus, that can also predispose one to aspiration. And also when you have neuromuscular disorders that would impair the gag reflex, and when you have deglutition or swallowing abnormalities, that can also predispose one to aspiration. So in terms of the clinical and the radiological manifestations, they can vary from focal disease that have no radiological abnormalities to very severe disease. And the major complications of aspiration pneumonia include pulmonary infections, and these infections, they tend to be confined within a lobe or a segment. So having lobe or segmental pneumonia, and more specifically, it tends to affect the posterior segments of the upper lobes and the superior segments of the lower lobes. So other complications include bronchopneumonia, lung abscesses, or empyema. So aspiration pneumonia, the features, they tend to mimic other pathologies like alveolar proteinosis, neoplasms like bronchogenic carcinomas and bronchoalveolar cell carcinomas. So it's really important to have a history and high index of suspicion that will point you either towards thinking about aspiration pneumonia or these other alternative pathologies. So CT has proven to be useful in the evaluation of diseases that are not visible on chest radiographs because we said initially they can be focal, not even initially, it can be focal, so you need a CT scan to help rule that in or out. So we look at different causes of aspiration pneumonia. So first we'll start with tracheopharyngeal fistulas. It can be congenital or acquired. So clinically, the congenital type typically affects neonates, and they will clinically present with recurrent pneumonias. And initially, in the acute setting, they will have a pneumonia. They can have a pneumonia or respiratory distress. So the most common radiographic finding is a bronchopneumonia with patchy airspace areas of increased opacities. And the most useful diagnostic imaging modality to help demonstrate that fistula's connection is esophagography with low smaller contrast media, which is the safest if there's this risk of aspiration. So on the image to the right, we have a baby who is 3 days old, and in this case, it's demonstrating a tracheopharyngeal fistula. So we have barium contrast within the esophagus, as you can see outlined posteriorly, and then anterior to it, we can see there is a connection between the esophagus and the trachea, and you can see contrast has it has gone deeper into the bronchi and the bronchioles because you can see all this branching into into the lungs itself. So this is a case of congenital tracheoesophageal fistula. So the next is the acquired type. The acquired type is commonly seen in adults, and it can occur as a result of commonly occurs as a complication of other conditions, top of the list being intrathoracic malignancies, especially esophageal malignancies. So it can also occur secondary to infections, trauma, post-radiation therapy to the region of the esophagus. So it's important to note that once these individuals develop tracheoesophageal fistulas as a complication of these conditions, their prognosis tends to be very poor. So diagnosis should be strongly suspected in patients with a known esophageal carcinoma who have evidence of recurrent pneumonias. So diagnosis is usually made with the aid of contrast. So in this case, we're talking about fluoroscopic procedures, and a CT may be useful in the diagnosis of a fistula in a patient with normal findings at an esophagogram. So that cannot solely exclude that fistula's connection. So what you can see in this image, we have an esophagogram, and it's illustrating a connection with the adjacent bronchi because you can see contrast within the bronchioles, and it's even extending to the alveoli in the adjacent lung. So this is a case of a 65-year-old man post radiation. They developed pulmonary esophageal fistula in advanced esophageal carcinoma. So we can see that well illustrated here. So next we look at aspiration of liquids, and in this case the liquid we're going to be looking at is gastric acid aspiration, and this will result in Mendelssohn syndrome. So for Mendelssohn syndrome, the pathologic reactions will vary from mild disease, where you have mild bronchiolitis, to hemorrhagic pulmonary edema. And aspiration of gastric acid is commonly seen with individuals who have vomiting, persistent vomiting, gastroesophageal reflux. Achalasia when you have poor relaxation of the lower esophageal sphincter, and in patients who have hiatal hernias. So mortality rates can be as high up as 30% when you have massive cases of aspiration. So the classical radiological findings in acute gastric acid aspiration will include bilateral, perihilar, ill-defined alveolar consolidations, multifocal patchy infiltrates, and segmental or lobar consolidation that affects one or both lung bases. So in this next slide, we have two images on the screen, and it shows a case of acute aspiration pneumonia in a 68-year-old man who had undergone surgery secondary to intestinal obstruction. So image A and image B were taken 2 hours apart, and what's illustrated here is a focal consolidation over the right lower lobe in image A, and the left lung field doesn't look, it looks normal despite having these hilar consolidations. So 24 hours later, now you have these new developed patchy consolidations that are apparent, now bilateral, affecting both the right and the left hilar regions. So next we have near drowning.
What was that new finding?
So the new development now is this patchy consolidation that's now affecting the left hilar region as compared to the right
It's
side.
not like actually, it's more extensive on both right and left lungs. It's upper and lower zones on both sides. So what do you think is now going on? What is the new finding if you are reporting these radiographs and knowing that the difference only 2 hours and had only one episode of aspiration? And remember, when somebody aspirates, they tend to go more to the right side, an adult, because of the vertical bronchus on the right. So what's going on? It's actually there in your ligand.
Yes, these are signs of acute pulmonary edema.
Yes, they develop acute pulmonary edema, which, by the way, can also mean they had ARDS. This was a reaction to the acid, to the pneumonitis
Yes.
as a result of the aspiration. Yeah.
Yes. Thank you. So next we have near drowning. So acute aspiration of massive amounts of water produces a pulmonary edema that is indistinguishable from other causes of pulmonary edema. And in near drowning, the volume of water aspirated is more significant than whether the water that's aspirated is fresh or salty. So in mild near drowning cases, you can have patients who have normal looking radiographs, or they can have confluent irregular perihilar opacities that have a segmental distribution with peripheral sparing. So unfortunately, I didn't get one that shows that peripheral sparing quite well. But in this next image, we can see a classical chest radiograph that shows these fluffy consolidations affecting both the right and the left lower lung fields. Yes, lower lung field. So this is a case of near drowning in a 46-year-old man, and it shows bilateral pulmonary edema. Then lastly, we'll go to exogenous lipoid pneumonia, which can be acute or chronic. So first we'll start with acute, and lipoid pneumonias occur as a result of aspiration of liquid paraffin or petroleum, so lipid containing substances. So it commonly happens, this acute type commonly happens in children following accidental poisoning. And then also it tends to occur in fire eaters who work at carnivals, people who blow fires because they use paraffin within their mouth. So they develop this condition called fire eater pneumonia, where they form pneumatocells or thin-walled collections of air within their lungs. So the image to the right, we have a radiograph in a patient who has acute fire eater pneumonia. So this is a 21-year-old man who has aspirated petroleum during a performance. So in this PA radiograph, you can see nodular areas on the right, bilaterally on the right and the left lower lung zones. Yes, and in this case, you can appreciate that the nodular opacities together with that history. So in the chronic type, it's caused by the repeated aspiration or inhalation of mineral oil. So it tends to affect adults who use mineral oil for the treatment of constipation, or adults who use oily nose drops for the treatment of chronic rhinitis, mainly at bedtime. So that's how it finds its ways to the bronchial tree. So once this oil has gotten into the alveolar spaces, that oil gets emulsified by lung lipase, and then following that you get now a reaction occurring within the air spaces. So to diagnose this condition, CT is a modality of choice. Clinically, most patients, they tend to be asymptomatic, but when they become symptomatic, then the CT will be done, and it will show that crazy paving pattern that was earlier mentioned, where you'll see ground glass opacities with thickened interlobar septa. So that is what you're going to see in these next images. So we have a patient who has lipoid pneumonia. So it's a 56-year-old man with cough and fever who had undergone laryngectomy. So in image A, it's a PHS radiograph that demonstrates a loculated pleural collection and bilateral ill-defined parenchymal areas of increased opacities. So we can see that quite well. And then on image B, we can see it's a axial CT chest lung window, and it shows ground glass attenuation in the left lower lobe. And then on image C, we can see it's an axial CT chest, mediastinal window, and in this case it demonstrates segmental consolidations within the right lung, and these areas of consolidations had fat attenuations of negative 40. So this corresponds to the causative agent that we said also is fat containing. So this is the case of chronic exogenous leukoid pneumonia. So that's it for the 3 topics that I had to cover. Are there any questions?
Yeah, are there any questions?
Yeah, thank you for the presentation. Also, thank you, Dr. Mango, for elaborating how we can approach the esophageal emergencies. I was reasoning like for the chest X-ray. I know we are doing a lot of chest X-rays downstairs, PAAP, adult, newborn. Um, at what point, I know what most of the indications for lateral chest radiograph would be for evaluation of retrosternal and retrocardiac opacification, as well as probably localization of opacities and maybe pleural effusions. But which are some of the indications we can really pursue? Because I know most of the time the practice has been the usual practice. If something is suspicious, finding on just radiograph, people tend to move just to CT. I don't know what will be the utility of a lateral chest radiograph.
Right, let's see what the class thinks before I give my comments.
They are useful. The lateral radiographs are very useful in helping to localize lesions, although I've noticed that for some reason the radiographers they don't like doing them. Because even when it's specifically requested that the requesting doctor writes there they want AP and lateral views, most of the times they will only get only one view is taken. I'm not sure why that is.
It's actually to do with radiation protection, reducing the amount of radiation dose. So if one can pick the abnormality in one view, usually the frontal P or AP, then you don't need a lateral view. But it's when you see something in a AP or PA and you want to look at it further, then you ask for a lateral view. As are now the radiologist, the one who's reporting, we're the ones who now ask for the lateral view, especially when you also suspect a mediastinal lesion, then you can ask for a lateral view to again localize it better. But if you were to look for the signs that can tell you this is anterior, middle, or posterior, you may be able actually to give a fairly adequate report in just one view. Sharon, you wanted to say something before I jumped in?
No.
Oh, okay. Yeah. But usually when somebody asks for a lateral view, there must be something specific they're looking for. So usually if the AP or the frontal is totally bizarre, then the lateral will not really help you. You need to know what it is that you want to look at. So again, to look for lymph nodes, then again, one would ask for a lateral view, especially when you're not so sure this prominent hilum, especially in children. Is it because of the mild rotation or the respiratory phase? Then you can now confirm on a lateral view. Where you also want to be clear that what you're looking at is maybe on the chest wall or it's intrathoracic. Again, you can ask for an orthogonal view. So each case you evaluate it and request for the requisite imaging. Again, bearing in mind that you just want to be diagnostic. You don't want to expose a patient unnecessarily. Yeah. So the imaging protocols in each department also determines what is going to be done. No? Yeah. Any other question? About MRI and diaphragmatic rupture. MRI
Yes.
is the most sensitive because of soft tissue. So you can
Mhm.
actually see the diaphragmatic muscle quite well. It's just that the modality itself does not lend itself very well in acute cases. And that's why we would not do an MRI if we can pick whatever we need to pick on a CT.
All right.
Mm. Yeah. Actually, radiology key explains it quite well. Eh? I noticed you avoided it, but you went to Medscape.
Yes. Okay. Look at
Yeah.
it.
But you had a lot of barium swallows and meals, and I think you got those from Medscape, isn't it?
It was Harris
Oh,
and
Harris. Mhm.
radio. Yeah.
Ah, okay, because radiopedia didn't you didn't list radiopedia in your references.
Oh.
Hmm. But that is good. Both of you, Sharon and Taleni, have done an excellent job, and people are not even asking questions, which is good. And you also showed us a case, one of the patients that you had seen, which has also made it more underlined the reason of why we are doing this series. So are we finished chest, or we are going to another system, or there's still some more to be done?
No, we finished chest. Now we're moving to the next system.
To which one?
Let me just confirm in a few.
The next system is cardiovascular, covered by me and Dr. Raul.
Oh, okay, fine. So expect questions from Derek, huh?
Yes.
Okay, fine. Right. Have a good evening, everyone.
You too. Thank you.
Thank you.
Thank you, Dr. Mango.
Yeah, karibuni.
So hii inakaa ni internet issue. Now what do I do? No, no. No, no, what does have come?